Hi everybody, this is Matthew Moake, and today we're going to talk about pyloric stenosis. We'll start with a quick case vignette. We've got our 4-week-old male presenting with progressively worsening vomiting for the past 3 days. His vomiting is described as non-bloody, non-bilious, and the parents happen to use the word projectile. He has continued to have interest in feeding, but parents note he is becoming progressively more fatigued, and over the past couple of days they've seen his urine output decrease from his baseline of about 10 diapers per day down to about 3 diapers as of today. As a quick review, pyloric stenosis is a congenital hypertrophy of the pyloric sphincter. It produces projectile non-bilious vomiting. Patients typically present between ages of 3 and 12 weeks of age. There's a male predominance and predominance among firstborn children. There's a number of risk factors, including prematurity, maternal smoking, exposure to macrolide antibiotics, particularly erythromycin, and there is some family history link. Parents who have had pyloric stenosis are more likely to have kids who also have pyloric stenosis. The classic boards questions include the physical exam, palpation of an epigastric olive-shaped mass, as well as the visualization of peristalsis within the abdominal wall. And the lab abnormalities that are classically described are the hypochloremic, hypokalemic, metabolic alkalosis. The treatment is a pyloromyotomy. As an overview for today's ultrasound lecture, we're going to discuss the normal bowel anatomy, the epigastric anatomy, review the scanning technique for pyloric stenosis, review findings in pyloric stenosis, and look at a little bit of evidence. The bowel wall is constructed of 5 different sonographic layers. Those include the outer hyperechoic serosa, followed by the hypoechoic muscularis propriae, the hyperechoic submucosa, the hypoechoic muscularis mucosa, and the hyperechoic mucosal air interface. On the left is an actual image of the stomach and the pylorus, and in pyloric stenosis, the layer that we're going to be measuring is that hypoechoic muscularis propriae, which is located right here. Seen in transverse, these alternating hyperechoic and hypoechoic layers of the bowel wall give us a target appearance of alternating bright, dark, bright layers within that bowel wall, as shown here. Another key when performing bowel ultrasound is the use of graded compression. The use of graded compression provides 2 primary goals. The first is to displace overlying gas and fecal material. The second is to decrease the distance from your probe to the deeper structures, and by doing that you get increased resolution. As noted in the quote shown here from the manuscript listed, a couple of key tips with this are to try to match your compression with the patient's respiratory cycle. As they slowly breathe out, the abdominal wall relaxes, you can press in deeper, and then you can make use of 2 hands to provide steadier, cleaner pressure and also control your probe more consistently. Next, we'll look at the epigastric anatomy. One of the nice things about pyloric stenosis scan, in contrast, say, to our appendicitis or intussusception scans, is the pylorus is consistently located at the distal outlet of the stomach. It's not a matter of knowing where in the abdomen it is, it's a matter of seeing it in its established anatomic location. So as you can see here, we've got an ultrasound image on the right and an anatomic drawing on the left. You've got your stomach transitioning from the body to the antrum. The pylorus is going to be the distal end of the stomach. It's going to begin at the angularia incisura, which you can sometimes make out in your ultrasound imaging as a little notch on the outer gastric wall. And it's going to transition over here as you've crossed over into midline, transitioning over to the first portion of the duodenum. Reflected off from here and going to be in close juxtaposition in your imaging is going to be your liver and your gallbladder. And as you can see here on the right, we've got an image that has our liver here, our gallbladder, your stomach body here, and your pylorus is sitting right here. This is a very classic orientation for the pyloric anatomy, and it's going to be the same general area you're going to be looking at if you're looking at your biliary ultrasound as well. Your probe of choice for this exam is going to be the linear probe. You want that high-frequency probe to give you maximal resolution. You don't need a lot of depth for this. Remember, your patients are going to be 1 to 2 months old, so with the linear you're going to be able to cleanly see the full depth that you're going to need. Positioning for this exam is really going to be whatever position makes the baby the happiest. These babies are fussy, they're hungry, they're crying, they're going to want to move around a lot, so try to have your parents hold them in whatever position makes them comfortable and still allows you to get to the anterior abdominal wall. When performing this study, again, you want to use a linear probe, and really any position that works. Typically supine is going to be the most common. You're going to want to place your probe in the subcostal or transcostal location just right of midline, and oftentimes in a slightly oblique to transverse orientation. The goal for this study is to identify the anterior gastric wall and the liver edge, and then track right and caudally as you track the stomach down through the antrum and ultimately ending in the pylorus. You want to obtain a long and orthogonal short axis view of the pylorus and make measurements as we'll show. There's 2 primary windows you can make use of for this. I personally tend to use more of a subcostal view and put my probe right underneath the rib cage. The downside with that is that you may end up with overlying bowel gas obscuring your view of the pylorus. The alternative is to slide up over the rib cage and use the liver as a sonographic window, which will help to avoid some intervening bowel gas, but also tends to put the pylorus further away from you. An alternative technique is to place your patient in the prone position and to use a right posterior probe location to look from the back anterior. I personally have not done this, but it is one of the described approaches. Some general scanning tips when trying to evaluate for pyloric stenosis. Again, have your parents hold the baby in whatever position makes the kid happy. Definitely use a pacifier with sweeties on it, and always use warm gel. You don't want to have cold gel make your baby even more fussy. Try feeding the baby before you do your scan. This will accomplish a couple of different things. First, it makes the kid happy. It also tends to provide you with a better acoustic window. You're going to fill that stomach now with fluid as opposed to the air that they've got entrained from screaming. Do be aware that when you feed the baby, a lot of times it's going to make the pylorus pitch down deeper into the abdomen. A lot of times it's going to go almost vertical, but that usually is well worth the better window that you're going to get. This is an exam where I will often use 2 hands to scan. This baby's going to be crying, your abdominal wall is going to be bouncing all over the place, and you're looking for a very small structure. So having 2 hands, both to maximize your graded compression as well as to keep your probe still, are really going to help you. With that, remember that you have your cine loop running, so if you see something pass through but you didn't have your video clip going, just stop, hit freeze, pan back, and you can still get that image. And patience. This is definitely one of those studies where you've got to have a lot of patience. These are not going to be patients who just sit still for you. You get those crisp images. It really does take a lot of patience to get this study. To emphasize that, here is a still frame from Pyloric Stenosis study. This is actually a fairly clean shot. You've got your stomach sitting here. This patient was fed shortly before the study, so you've got a nice full stomach of liquid here. The pylorus is diving down here. You don't get a great view of all the anatomy, but this is the actual pyloric wall here. This, even right away without any measurements, I can tell you is a pyloric stenosis. However, in real time, this is what this actually looks like. As you can see here, this is a fussy baby. They're crying. With their crying, their abdominal muscles are moving. They're moving their belly up and down. The ribs are moving. You can see the liver popping into view, the gallbladder popping into view. You see the stomach coming in and out of view, the pylorus coming in and out of view. But remember, all you got to do is hit freeze, pan back through some of these images, and then you can go back and get those clips of the pylorus and make your measurements if needed. Comparing a couple of your acoustic window options, again, you can do a transcostal or subcostal approach. These are images actually from the exact same patient. The upper image is one performed by our radiology department using a transcostal approach, and with that you can see the liver sitting here between the skin surface and the stomach and pylorus down here. The image on the bottom is a subcostal approach performed by me. In this case, you can see we don't have the liver in the way. We've got our probe basically sitting right on top of the stomach, pylorus sitting here, transitioning into duodenum. This was a nice, normal pyloric stenosis study here. Comparing these 2 images, you can get a sense, you get a lot closer to the pylorus by doing the subcostal approach, but you may risk overlying bowel gas getting in your way. Next, we'll discuss the ultrasound findings in pyloric stenosis. Remember, the bowel wall is constructed in 5 different sonographic layers that can be visualized with the linear probe. When we're assessing for pyloric stenosis, what we really want to look at is the pyloric muscle, and with that we're actually looking at that hypoechoic muscularis propria level, which is sitting right here. And when we do that, our criteria are to have a single muscle width of more than 3 millimeters, which is right here. A total width of the pylorus, that is to say the entire width from that outer hyperechoic layer to the outer hyperechoic layer of more than 7 millimeters, that would be here to here. A pyloric channel length of greater than 14 millimeters, that's measuring from here to here. And then additionally, the absence of transpyloric gastric flow. The reason these patients are vomiting is they're having gastric outlet obstruction, and so none of the gastric content should be seen flowing from the stomach out this channel because it's hypertrophied and blocked up. Conveniently, you can remember these main measurements with the mnemonic of pi, so 3.14, 3 millimeters for your single muscle width, and 14 millimeters for your pyloric channel length. Taking a little bit closer look at pylorus size, there is some variability in pyloric measurements based on gestational age as well as patient weight. This study retrospectively looked at 189 surgically proven pyloric stenosis patients. They had a mean age of 4.6 weeks, mean weight of 3.9 kilograms, and mean muscle thickness of 0.42. They found a statistically significant relationship between the muscle thickness and both age and weight, as you can see in the figures to the right. With this information, you basically want to keep in mind that you've got a patient that's a little bit younger, a little bit lower weight, and your measurements are a little bit borderline. Those may very well be pyloric stenosis, and they just might not be meeting those classic cutoffs if they're in those smaller size categories. Another concept to keep in mind if you're getting those borderline measurements that aren't quite reading that 3 millimeter mark but just a little bit shy is the potential for pylorospasm. This occurs when the pylorus is contracting. It obviously gets thicker when it contracts, and with that contraction, that thickness may start to approach the level of pyloric stenosis. Usually you're not going to clear that full 3 millimeter mark. It's typically going to be more in like the 2 to 2.5 range. But if you have a patient where that is getting close, you may want to consider repeating your evaluation a little bit just to make sure that it's not persistently maintaining that enlarged size, and you know that you're not on one of these borderline cutoff cases, because if it's pylorospasm, it should relax eventually, whereas if it's pyloric stenosis, that muscle is not going to get any thinner. Here we have an example of a very normal pylorus. These are both videos in real time. What you can see here is we have the liver in the near field. You've got your stomach body sitting here in kind of the upper right. And on both these you can see you've got this kind of isoechoic appearing, fairly homogeneous gastric content. You can see within the top part of the stomach you've got a little bit of hyperechoic area. This is a little bit residual air that's entrained in the stomach. And as you follow the stomach down, you can see it starts to taper. You're getting into the antrum down here, and eventually it tapers down into your pyloric area in here. Now, in a lot of cases, the pylorus itself doesn't really stand out from the rest of the stomach when you quickly look. I'll say when you look at our own radiology departments, in normal pyloric ultrasound studies, they routinely are not making any measurements. You can tell just qualitatively there's nothing enlarged, there's nothing worth measuring. You can see this gastric content is coming through here, and it looks to be freely flowing out the back end of the stomach here. Here's another couple of normal images. The video on the right shows now a little bit different looking gastric content. You can see you've got largely hypoechoic content with these very hyperechoic signals in it. These are little bits of particulate matter in the stomach that have some air trapped with them, so you've got these little kind of starry night appearance. Here's your gastric body here. You can see it tapering down to the pylorus here, and as you watch, you can see some of these bubbles making their way out, and they occasionally kind of slip out this channel here, but there's no big meaty chunk of muscle sitting here, and you're intermittently seeing your gallbladder popping in on the screen left. On the right, we've taken a freeze frame and attempted to make some measurements on this. You can see it almost looks like you're making up a little bit of this, and I would agree these aren't exactly perfect, but there's nothing here that even stands out close to the measurements you're going to get for pyloric stenosis. Contrasting that, so we have a normal here on the left, trying to make some measurements, but again, it almost seems like you're hallucinating where you're actually putting those calipers. In the middle on the right, we have a couple examples of pyloric stenosis. What you can see here in both of these is a dramatically enlarged single muscle layer. So in this case, here is our muscle layer here, this hypoechoic layer of that muscularis propriae. So your bright, dark, bright layer down here. So this is the muscle you want to measure. So this has got to be greater than 3 here. And then you want to measure your channel length, measured here with the calipers from here to here. That's got to be greater than 14. Similarly, you can measure the far side muscle. You could also measure the entire width from here to here. I will say I very rarely do that. I usually just throw my calipers on the muscle and the channel length, and things are sort of taken care of. A couple other still views of these and some signs you'll see described. So in long axis, the other things you'll hear described are the antral nipple. What that refers to, as shown here on the left, is actually some of that mucosa of the pyloric channel basically being squeezed out of the channel into the gastric body itself, and that's just because of this enlarged muscles creating enough pressure that's actually pushing the mucosa out in here. You'll also see, which we don't have labeled here, something called the shoulder sign reference to, and that is the appearance, if you remember your 80s fashion, the pyloric muscle gets so big that it starts to put these shoulders out into the gastric body itself, and you get this bump in the muscle back into the stomach. In transverse, you'll often hear a reference to the target sign. Pretty much every one of our bowel pathology has something that calls a target sign or a bullseye. In this case, you're seeing the pylorus on cross-section, and you've got this nice thick muscle layer, and then your underlying channel down in here. You could also make your measurements here, as well as here, or measure the full tract here. The key, if you think about measuring it that way, is you want to make sure you have a truly perpendicular image. If you think about the shape of a cylinder, or using this example here on the left, you want to make sure you're cleanly perpendicular here, because if you take a measurement that comes more obliquely, say coming across like this, you would make this artificially large. I personally tend to take my measurements in the long axis. I think it visualize it better. And if you get a maximal size there, you're not going to give yourself an artificial enlargement. Another sign you'll see referenced is shown on the right, called the cervix sign. For those of you who've done any OB or GYN ultrasound, you recognize that the pylorus does have an appearance that looks quite a bit like the muscular cervix when you're assessing for the cervix and uterus. Another key finding in pyloric stenosis is the absence of transpyloric flow. On the left, we have a normal appearing pylorus and stomach with very easily seen transpyloric flow. As you watch this, you can see your stomach is here, pylorus is sitting somewhere about here. You can see this sort of heterogeneous stomach content, and you can see it freely flowing out this channel that's opening up, and this content is dumping out freely. You see this, you know you don't have pyloric stenosis. On the right, we have another large distended stomach here. You can see these muscle walls just churning, trying to get this gastric content out. You're not actually seeing the pylorus very well through most of this. It comes in right down here. What you ultimately see is that none of this stuff is managing to make its way out the channel. Visualized a little bit better, here's two more examples of pyloric stenosis. These are two different patients. Both of these on screen right, you've got the stomach here and stomach here. You've got your thickened pyloric muscle here, thickened pyloric muscle here. And what you can see is the stomach is sort of churning in both of these. You've got this content in them, but nothing ever makes its way out of this channel here. And this one you can see it really well. You've got your content here. This channel is completely closed, nothing is passing through, and you have your first portion of duodenum sitting here just praying to get some sort of content. That's not going to happen. We'll look at just a couple more examples of normal and abnormal. Here we are again, normal pylorus, easily viewed transpyloric flow. You've got this hyperechoic gastric content. This is owing to a whole bunch of admixed air into this, and you've got this dirty shadow coming from that air, but you can see this content freely passing out this pyloric channel here into the duodenum. Here we have that still view, gastric content. Easily visualized open channel. You can see your pylorus is probably ending right here. You get that little nubbin of the angular incisura here, and we're measuring this muscle here, 0.07, very normal. Here we have a case of an abnormal gastric body over here, pylorus here in real time. You can see thickened muscles. Things are trying to make their way out. The stomach is moving along, but nothing is making its way out. You throw your measurements on. We measure this muscle. It's greater than 3. Pyloric channel you can see is over 14. One thing you will notice when you do these measurements, your pylorus is often a little bit angled, and so you can either choose to make a couple of individual measurements and add them up to measure the channel. A single measurement may ultimately undermeasure that channel length, but if that single undermeasured length is over your cutoff, you don't really need to bother with it. Another example of abnormal here, Again, the video on the left, you can see big distended stomach, fairly hysoechoic, homogeneous gastric content. See the stomach sort of squeezing along. This pylorus is thickened. Nothing is making its way out of that channel. And you can see on the right, we threw some calipers on. B and C collectively are measuring a pyloric channel, as we were just discussing, since that's nice and curved. In this case, chose to measure it in two different pieces. And then A is actually measuring something completely useless. Just ignore that measurement. Here we have one last abnormal case to show. On the left, this is again a little bit more realistic image of what these often look like, particularly when you put your probe down initially. As you look, you get a sense of your pylorus is sort of popping in and out of frame roughly in the middle of the screen here. You actually see your gallbladder coming in on the top left here. You've got some liver popping in. Gastric body is up here. You've got some hypoechoic content and then some hyperechoic air sitting here in these least dependent areas with that dirty shadowing coming down. Again, take your freeze frame, pause that. You can come in with your measurements. Measure our anterior muscle wall here. We're over 0.3. Measure our channel length. We're easily over 14. Also measured our far wall, over 0.3. And here on the bottom right, we have a transverse view. We're measuring that muscle wall, and it's also well above our cutoffs. Lastly, looking at a little bit of evidence for point-of-care ultrasound in evaluation of pyloric stenosis. This was a prospective observational study done in a single ED. They took 6 PIM fellows and 1 PIM attending. They did a 45-minute didactic and a little bit of hands-on scanning. All the participants in this study had less than 25 pyloric studies previously. They enrolled 67 patients, 10 of which were positive for pyloric stenosis. Of those, it's important to note that 40 of those patients and 3 of those pyloric stenosis patients were enrolled by the single attending, who was the most experienced of the group, so it does skew the data performance. In that study, they had 100% specificity and sensitivity for point-of-care ultrasound compared to the formal radiology study. Also importantly, there was no difference between the pyloric width or length measured by point-of-care versus radiology. Small single-centered study, but very nice performance in this one center. This study was a retrospective single-center study running from 2015 to 2019 with a total of 171 pyloric stenosis cases. They compared point-of-care only versus point-of-care transition to radiology and radiology study only. And in their study, point-of-care ultrasound had a sensitivity of 96.6%, specificity of 94%, and overall had decreased length of stay relative to radiology ultrasound. So again, high performance metrics, but with the added benefit of lowering patient stay. ED turnover is a big deal, so this is definitely an added benefit of your point-of-care study, both for this and really any point-of-care study. Finally, a few take-home points from today's lecture. The pylorus is identified at the caudal end of the stomach, but can be challenging to visualize due to abdominal wall movement and bowel gas. Small movements, graded compression, infant comfort measures, and patience are key to performing pyloric stenosis ultrasound. If obtaining borderline measurements, keep in mind age and weight variation, and consider prolonged repeat evaluation to account for pylorospasm. While limited, studies show that providers with minimal experience can accurately diagnose pyloric stenosis using point-of-care ultrasound with high sensitivity and specificity. That's it for today's lecture. Reach out to me with any questions.